then chief resident, then fellow, then attending, and now director of the intensive care unit. Dr. Simon would probably agree with me that Danielle is probably the best medical student we ever had at GW, a great resident, the second best chief resident, and now we take a lot of pride in seeing her advance all the way to be the director of the intensive care unit here at GW. You know, we lived through the last 5 months of COVID. We know what the Department of Medicine did. For the next 2 weeks, we're going to find out today what the ICU went through, and then next week what the emergency room or emergency department went through. So Danielle, thanks for doing this on relatively short notice, and it's all yours.
Second best chief resident?
No. I thought it was first. Okay, relegated to second. That's all good. Well, thank you so much for giving me the opportunity to speak here. So again, I'm going to talk about what we've learned from COVID-19, an ICU perspective. I have absolutely no disclosures. I am definitely not getting paid for this. So the objectives today, I hope to describe the lessons we learned from our preparations for COVID-19 pandemic.
This is the first peace treaty, diplomatic relations between Israel and an Arab nation in decades, made possible by Israel for now, giving
demonstrate the many clinical manifestations of COVID-19 and how ICU management changed as our understanding evolved and data emerged, and describe specific GW ICU COVID-19 demographics and outcomes, setting the stage for future research. So for the COVID timeline, Wuhan City became the center of an outbreak of pneumonia of unknown cause in December 12th of 2019. In January 7th, Chinese scientists isolated this novel coronavirus in 3 patients with a pneumonia known as SARS-CoV-2, later designated as COVID-19 by the WHO. The first case in the US was confirmed on January 20th. In February of 2020, we had our first death reported at Evergreen Hospital in Kirkland, Washington, linked to exposures in a skilled nursing facility. Then in the latter part of February and early March, we started getting the outbreaks in New York City and Boston. And our first case was reported in Washington, D.C. on March 7th. So what was the climate like in that time in the beginning of March with great uncertainty and anxiety as we entered into that preparation phase? So in early March, I like to call early March our preseason. When I asked one of my senior colleagues if they felt comfortable caring for patients and COVID-19 due to the infectious risks, the response to me was, "You got to be kidding me, Danny. This is like our Super Bowl." So nevertheless, I call March sort of our preseason time. And we were fortunate enough to have 2 to 3 weeks in March, allowing us time to prepare. As many as you know, GW was the first to suspend elective surgeries in the DC area on March 16th. And this really gave us opportunity and time to acquire equipment, create protocols, and align with other departments. So the GW ICU structure, we consist of 51 single beds distributed over 4 floors. We agreed that the negative pressure rooms would be on ICU 5 and ICU 4 to start, where patients would be. And then in the event of a surge, we would convert the one to 2 beds in each room for a total of 102 beds. The PACU would then convert to an ICU for an additional 48 beds, giving us a total of 50 beds. Our ventilators, our normal inventory is 39, so we increased that inventory to 150. We rented additional machines, anesthesia machines, transport vans, for example. Our monitors was actually our rate limiting step. We only actually were able to obtain 45 monitors, so there was the potential that patients would be on ventilators actually without monitors. We developed a tiered staffing strategy for the pandemic, whereby we had 2 ICU attendings supervising attendings from different services, as well as ICU fellows and APPs, basically at the next tier down, followed by residents from different services. Fortunately, we never needed to implement this plan. And protocols, we developed 27 protocols, mostly in the ICU, in a 2.5-week span. And I sort of joke that prior to COVID, it took us 9 months to develop a Foley protocol, literally telling nurses when to insert and remove Foleys. So I guess the lesson sort of learned here is that when there's a will, there's a way. This is an example on the right of our porting protocol. Prior to COVID, we used what's called a rotobed, which basically automatically flips patients at the press of a button in ARDS. And that machine was obviously not available in COVID. So we trained and we simulated, and that's us attending at the head of the bed, helping to maintain the airway. So we have several protocols. Some of them required significant discussion and modification throughout the last several months. The ECMO protocol, by way of example, in collaboration with our CT surgical colleagues, we agreed that the decision to cannulate and the decision to accept a patient for transfer depended on 2 things. Number 1, the patient characteristics. So we used the ELSO guidelines. I think we did become more conservative throughout the pandemic, realizing that we just really couldn't save everyone. And two, staffing. So we have a specialized nursing model with a 1-to-1 ratio with very highly trained nurses for ECMO. And these nurses are extremely valuable and a limited resource. So we did agree we would cohort 2 ECMO patients in one room, thereby basically preserving the nursing expertise. Our tracheostomy protocol we also learned from and also went through various modifications and interdisciplinary discussions. So initially we agreed that one would, in order to qualify for tracheostomy, you would qualify only if you had a negative COVID test on repeat testing, and they had to have a minimum of 3 weeks on the ventilator to basically prove that the patient survived long enough. But over time, we've realized that this really isn't realistic for a few reasons. Number one, we now know the PCR and COVID test is positive for like up to 6 weeks in some patients. And it's not realistic to wait for a negative test. It's likely just RNA shedding and probably safe to perform this trach with proper PPE. There's also something called, what's in the literature now called COVID glue. These are very thick secretions that patients develop within their endotracheal tube that basically suddenly like clog the endotracheal tube. And that requires the intensivist basically to emergently exchange the endotracheal tube at the bedside. So this really is not safe for the doctor, nor the nurse, nor the patient. So probably getting a tracheostomy earlier is probably best for everyone. And lastly, when patients are intubated for a very long period of time, they develop tracheal stenosis. And in fact, I was just speaking to one of my ENT colleagues who told me that actually almost a third of their practice now are COVID patients that have recovered and now have developed tracheal stenosis as a result of prolonged intubation. So we are actually now in the final stages of redeveloping or modifying our trach protocol. So our intubation protocol, I'm not going to go into great detail because I believe Dr. Yamani is going to talk about this next week, but this is a picture of Dr. Hawkins in her enhanced PPE. She's getting dressed in a PAPR prior to intubation by our safety officers. And a quick shout out to Dr. Paul Dangerfield in anesthesia. He's the person responsible for acquiring many of these PAPRs for us. And I think I would give my left kidney to this man because I really think he's the reason why we kept safe and continue to keep safe. We labeled all of our PAPRs by states so we could keep track of them. So equipment. In order to intubate, you have to intubate quickly and safely. This is on the left, a picture of our video CMAC machine that was always draped, always ready on both floors because you don't have time to take them through the elevator. We developed an intubation medication kit. This was basically to prevent delays of the nurse to go into the access and get into medication. And on to the right here, we have a ventilator that's always draped with an antiviral filter and on standby. So if somebody decompensates quickly, you just press the button very quickly, the patient's automatically on the ventilator. This is our COVID closet, which backup supplies, which is AKA my office. But I always wanted to have backup supplies in case somebody deteriorated and we needed equipment quickly. These drapes, by the way, are available on Amazon and Home Depot, which is where I got them. So our intubation protocol, again, I'm not going to go into great detail. However, I just want to say that intubating a patient is one of the most harrowing experience in a anesthesiologist or intensivist or EMED doc can have. We did agree that we would avoid bagging these patients in order to minimize the aerosolization, both before intubation and after intubation. So basically you just stick them directly onto the ventilator. So you're not pre-oxygenating them, and they have profound lung disease to start. So they desaturate dramatically. Patients desaturate to less than 5% in a matter of seconds when you're intubating them. And this is further sort of complicated by the fact that you're visually impaired when you're intubating the patient. So you're doing this through a PAPR screen. Your video CMAC machine is also covered. And in the beginning, at least, we were using these tents or drapes over here. This is a PA pretending to intubate my fellow. But anyway, this was really a pass-fail endeavor. If you didn't get it on your first time, the patient would die. And unfortunately, we have not had that occur. So our Code Blue protocol, to begin with, initially, I think there was a lot of ethical debate whether or not resuscitation was even warranted. If you look at even the pre-COVID data for in-hospital cardiac arrest, the outcomes are really pretty dismal, with non-shockable rhythms only reaching a survivability of about 20%. Improvements in survival are made by early and effective chest compressions, reduced time to defibrillation, and early epinephrine for non-shockable rhythms. But this is all really greatly affected by COVID with respect to its infectious control challenges. So this is a study in China of 136 COVID-19 patients who had in-hospital cardiac arrest. The origin of the cardiac arrest, the majority of them were respiratory, almost 90%. The majority of them occurred on the general ward, And the initial rhythm in close to 90% was asystole, so sort of setting the stage for a bad outcome. Only 13.2% achieved ROSC, only 4 patients survived to 30 days, and only 1 patient had a favorable neurologic outcome at disposition. What about safety of CPR with respect to the healthcare worker? Well, this is a simulator model that looked at the aerosolized spread during CPR using nebulized UV-sensitive detergent into a model, and basically monitored the spread when the healthcare worker was performing CPR with a surgical mask, performing CPR with an endotracheal tube, and performing CPR with an endotracheal tube and a filter. And what they found was most aerosolized spread at the direction of the provider occurred when CPR was done alone. So in other words, there was no protection. The use of the surgical mask on the simulator, on the dummy, did deflect the spread, but only minimally. However, if they inserted the endotracheal tube and put an airway filter on, an antiviral filter, this led to significant reduction of that aerosolized spread. So we decided for our in-hospital cardiac arrest patients for COVID-19, we would prioritize intubation for COVID-19 code. Now, this is different than ACLS protocol, but nevertheless, we did this for 2 reasons. Number one, as I demonstrated, respiratory is likely the underlying cause. And number 2, it's probably safest for staff. Of course, we did emphasize the importance of advanced directives. In our preseason time, we also talked about the importance of communication with patients and families. We were committed to making daily phone calls to families using our ICU iPad with FaceTime and Zoom. Of course, this sort of highlighted the language barriers and inequities that are so apparent. We also asked the hospital to purchase walkie-talkies for us. So we used walkie-talkies to communicate both in the hallway and to the nurse that was in the negative pressure room. And some other innovative sort of MacGyver type designs that we did, we basically jerry-rigged the ventilator so that the console and the controller was positioned outside of the patient's room, while the ventilator base and the machinery was inside the room. So we didn't have to go in and out of the room so much to manipulate the ventilator. We could do that. Some of our PAs even brought in binoculars. So preseason had ended and our first patient arrived. So this is a 59-year-old African-American man with a past medical history of hypertension who presented to an outside hospital on March 12th with diarrhea, fever, fatigue, and cough. He said he had contacts with coworkers who had traveled overseas, and he was admitted to the medical floor on oxygen support. This was his CT scan, which demonstrates the typical subpleural bilateral ground glass opacifications with ill-defined margins. This is a 3D image of this particular patient that Keith Mortman put together and is available actually on YouTube video. So at the outside hospital on hospital day 2, he required high flow nasal cannula and non-invasive ventilation. By hospital day 3, his respiratory failure had abruptly worsened, requiring intubation with rapid deterioration into ARDS. At that point, his COVID test is reported as positive. He has an echocardiogram done with normal cardiac function and an EF of 70%, and he's transported to GW for a higher level of care. When he arrives to GW, he's on 100% oxygen. He's on very high levels of PEEP. You can see his ABG there. His PO2 is only 73. We start a neuromuscular blockade infusion. His ventilator settings are changed to APRV, which is a sophisticated ventilator mode or apparatus for severe hypoxemia. And at that point, the GW ECMO team is consulted. And we decided at that point that we're going to put this patient on VA rather than VV ECMO because we had heard in reports about the sort of impending cytokine storm and hemodynamic instability that was to come. We thought we could sort of, I guess, trick the virus. So for those who are not familiar with ECMO, VA versus VV configuration, basically venous blood is drawn out of a major vein. It goes to a pump, then to a membrane lung and oxygenation, and there's gas exchange, and then it returns back to a major artery in the case of VA ECMO, or back to a major vein in the case of VV ECMO. So VV ECMO, So VA ECMO is for both heart and lung support or hemodynamic support, and VV ECMO is really for just lung support. So despite ECMO, the patient's hypoxemia persists. We diurese the patient, we perform intermittent recruitment maneuvers on the ventilator, we put a second oxygenator on the ECMO circuit, again, various adjustments to the ventilator, and despite that, his saturation is only 85%. We also note that the ECMO needs are actually increasing and escalating. So now he's up to a sweep of 10 to 13, which is basically maximum, and that's what removes the carbon dioxide. Interestingly, we also note that this patient's lungs are quite compliant. So that's sort of different than your typical ARDS patient. And if you look at the cannula over here to the right, you can see that he's starting to form clots. On hospital day 7, his creatinine, that evening, his creatinine goes from 1.7 to 2.7. His ferritin doubles, and by the morning, he's on 3 maximum pressors. His lactate has now gone from 4 to 6 to 13 and rising. He's now on CVVH, or continuous renal replacement therapy, in addition to bicarb. He's clotting, and you can see the difference between his EKG just 2 days apart, on hospital day 6 with a narrow QRS complex, and on hospital day 8, and he passes soon thereafter. You can see this is what his labs look like, his inflammatory markers. His ferritin had risen abruptly, his lactate rising, his oxygen saturation quickly desaturating. He had elevated D-dimer, elevated IL-6, as well as elevated troponin. So I think this case raises a lot of questions. Number one, what is the pathophysiology of this profound hypoxemia? Is this typical ARDS, or is this something else? The threshold to intubate. Is high flow nasal cannula safe and effective? What about this tendency to clot and the treatment algorithm for that? And what is the shock light state or cytokine storm? So first, what is the incidence of severe pulmonary disease in COVID-19? Well, the answer is not really clear. We know the median time to develop dyspnea is about 5 to 8 days, and the median time for those who develop ARDS is 7 to 10 days. But the rates of mechanical ventilation and the mortality associated with mechanical ventilation really vary significantly, mostly because the threshold to intubate really changed during the COVID-19 pandemic. So if you look at the percentage of ICU patients that require invasive mechanical ventilation, if you look at the different studies, for example, a study here by Wang in China, only 29% of patients in the ICU required mechanical ventilation, as opposed to New York, where close to 90% of patients required mechanical ventilation. Furthermore, if you look at the mortality while on mechanical ventilation, that varied significantly as well. So in China, the mortality rates from 4 different studies varied from 52 to 81%. In Italy, 26% of patients requiring mechanical ventilation died. However, 58% still remained intubated at the end of the study. In Seattle, between 61 and 75% of patients requiring mechanical ventilation died. This is sort of similar stats that we have to GW. In New York, a study came out where 88.1% of patients requiring mechanical ventilation died. However, patients were excluded if they were still on mechanical ventilation and still alive at the time of the analysis. And on the other extreme, in Atlanta, only 29.7% of patients requiring mechanical ventilation died. So a lot of variability. Well, the mortality rates on mechanical ventilation probably vary so much because it depends on the interpretation of the data. So again, the majority of patients were still receiving care at the time of analysis. So if you incorporate the range of possibilities, both the best and the worst outcomes, the range of possible mortality is actually quite large. Nevertheless, despite this variability, the survivability of COVID-19 while requiring ventilation is exceedingly poor. So this raises many questions. Is the ventilator even helping at all, or just inducing lung injury? What about resource limitation? At some point, intubating everyone becomes untenable. And then the methods to avoid intubation, such as high flow nasal cannula or non-invasive ventilation, what's the real risk of aerosolization? Is this real or theoretical? Or is this just delaying the inevitable intubation? Initially, most studies recommend actually avoiding this modality, avoiding high flow nasal cannula. So many case reports started coming out that demonstrate that sort of delayed intubation strategy is probably safe and possibly effective. So this is one study, 4 patients who were initially intubated early and compared to 6 patients who initial SATs were in the 80s, very, very similar, but those patients received high flow nasal cannula and were asked to self-prone. So of the 6 patients that were not intubated early, 2 eventually were intubated. However, all 6 of those patients were discharged earlier compared to the patients that were intubated much earlier, who still remained intubated at the end of the study. So what is high flow nasal cannula? It's basically regular nasal cannula. However, it's warmed and humidified. And because of that, you're allowed to get flows anywhere up to 40 to 60 liters per minute. And there's several advantages to high flow nasal cannula. Because of these high flows, you basically can match the patient's inspiratory flow rate. So if a patient's breathing hard, you can increase the flows and match that patient. It's much more comfortable for the patient. With these high flows, you can use a small amount of PEEP. And because the prongs within a high flow nasal cannula are large and basically occlude the nares, there's less ambient air that's entrained. So you get a lot of bang for your buck. What's the efficacy of high-flow nasal cannula? This is a well-known ARDS fluorally study that demonstrated patients with moderate to severe ARDS were less likely to require mechanical ventilation and less likely to die at 90 days if they received high-flow nasal cannula compared to high conventional oxygen with ARDS. Well, what about the safety of aerosolization? This is a high-fidelity mannequin study, and they looked at used a laser to detect the dispersion of oil particles as the simulator sort of exhaled with high-flow nasal cannula and CPAP at different flow rates and different severity of lung disease. So if you look at high-flow nasal cannula dispersion, at 60 liters per minute of flow, even with a normal lung, all you got was basically a dispersion of 17 centimeters or less than a foot. But even in a diseased lung, there was hardly any dispersion, so probably safe. So in sum, no evidence that high-flow nasal cannula at least is unsafe. High-flow nasal cannula was being increasingly used for this delayed intubation strategy, and societies are now actually recommending high-flow nasal cannula for COVID-19 pneumonia. Non-invasive ventilation remains controversial. It is supported by the Society of Critical Care Medicine, although there are several caveats regarding safety. So some of the logistics we had to consider with high-flow nasal cannula, we first had to increase our inventory, increase from 20 to 60. At one point, we had 55 patients on high-flow nasal cannula between the floor and the ICU. With respect to monitoring, there is a non-trivial risk of a patient who discontinues their high-flow nasal cannula. Specifically on the floors, unfortunately, there were a lot of rooms that didn't have windows, and this was a problem. So some of the interventions that we did, we asked the hospital to build some windows. We changed the nursing ratios on the floor. The nurses and respiratory therapists were now trained to titrate the flow and the oxygen. A shout out to the rapid response nurses and the hospitalists and medicine residents, our colleagues who really just took this on and took care of a lot of these patients on the floor that they had not done so previously. What about the threshold to transfer patients to the ICU? We generally used our clinical judgment. Our rapid response nurses are excellent, but there are objective measures out there, such as the ROX index, that uses a cutoff of 4.88 to determine whether or not a patient needs to be intubated. Another great strategy to avoid intubation is proning, both awake or intubated, also known as tummy time. So there's physiologic rationale behind this. When a patient is in the supine position, the dorsal lung is compressed by the weight of the heart, the ventral lung, and the abdominal viscera. In the prone position, the mediastinum is now supported by the sternum, and the dorsal alveoli are allowed to expand significantly. With respect to perfusion, there is always more blood in the dorsal lung due to gravitational forces. So when you put a patient in the prone position, the ventilation now matches the perfusion. You can really enhance that ventilation perfusion matching. So there is some evidence in COVID-19. This is a small study at Columbia University. They included patients whose SATs were less than 93% while on 6 nasal cannula or non-rebreather. They asked patients to awake prone for 24 hours or at least as much as they could tolerate. And all patients had an improvement in saturation. And particularly patients whose SATs were greater than 95% after an hour of proning was associated with a lower rate of intubation. And finally, our last step at preventing intubation, of course, is our fantastic palliative care colleagues who had many, many end-of-life discussions and goals of care discussion with our patients. So we did have several successes with this strategy. This is an example of a 64-year-old man who was admitted to the floor on nasal cannula. Rapid response, was called on the first day as his rate was in the 30s and he was desaturating to the 80s. He became tachypnic with a respiratory rate up to the 50s, just moving over to the ICU bed. At that point, we decided to put him on high-flow nasal cannula and non-rebreather and ask him to self-prone. So we deferred the intubation. Now, pre-COVID times, this is the patient we would definitely have intubated. His oxygen saturations definitely fluctuated over 4 days, but he was eventually weaned, transferred to the floor, and discharged to home. You can see his x-ray over here. This is with his gastric bubble on the other side because he's prone. So of course, this was a successful story, but not all of our patients were successes, and many patients did go on to intubation. So as a group, as an ICU group, we agreed during the pre-COVID time that we would be committed to our COVID patients using ARDS-NET protocol. So this means low tidal volume, 6 cc's per kg of predictive body weight, low plateau pressures on the vents to protect the patient's lungs while the patient was intubated. Treatment of typical ARDS. However, when we were taking care of these COVID patients, it became apparent that many of these patients didn't have necessarily this typical ARDS. In fact, they had such profound hypoxemia that seemed to outweigh the X-ray, the mild X-ray findings, and these very, very compliant lungs. So on March 30th, a rather controversial article came out by Dr. Gattinoni that stated these patients with COVID-19 pneumonia fulfilling the Berlin criteria of ARDS present an atypical form of this syndrome and deemed the primary characteristics of this that we're observing, confirmed by colleagues in other hospitals, is this disassociation between their relatively well-preserved lung mechanics and the severity of hypoxemia. And what he demonstrated, and colleagues demonstrated here, that just 16 patients, but multiple observations, that these patients' compliance was about 50, which is very compliant, and which was not in proportion to their hypoxemia. So he and colleagues coined this term called CARDS, or COVID ARDS, and he described two phenotypes. The first phenotype is L phenotype. These are patients who have very, very compliant lungs, flexible lungs, not classic ARDS. Their hypoxemia is due to low ventilation perfusion ratios at the level of the vasculature, and these are not weighty lungs. So again, not typical of ARDS. These are sort of those silent hypoxic, the patient that comes into the emergency department who's a little bit tachypnic and you put the pulse ox on them and their SATs is like 55%. These patients tolerate very, very high tidal volumes because their lungs are so compliant. And these patients, at least in theory, don't benefit from PEEP because again, the disease is at the level of the vasculature as opposed to the alveoli. This is in contrast to the H phenotype that they described. The H phenotype is very low compliant or very, very stiff lungs. So stiff, heavy lungs where the alveoli, instead of the vasculature, is filled with pulmonary edema or purulence. And these lungs are recruitable. So if you give them high PEEP, you can expand the alveoli. And the H phenotype is more of your typical ARDS, where you would use typical ARDS strategies and use PEEP, high PEEP strategies. Well, we probably believe at this point that there's probably a spectrum that PEEP probably start out at the end L phenotype and convert over to the H phenotype. So here are two examples. This is an example of the L phenotype. So this is a patient who is on not a significant amount of pressure, on APRV of 35 pressure, but if you can see his tidal volumes here, he has a tidal volume of 1,900. These are tremendous tidal volumes, very, very compliant lungs. And despite being on 100% FiO2, his saturations are only in the 78, 81%. So very compliant hypoxemic lungs. This is in stark contrast to the H phenotype. This is a patient who requires an extraordinary amount of pressure within the lungs, 73, 71, and his tidal volumes are only in the 200s. So this is a very, very, very stiff lungs, a patient who had barotrauma, required several chest tubes. And you can see we had a lot of difficulty ventilating him. His pH never got above 7.0 and his CO2 was in the hundreds. So this L phenotype, the theory is that the hypoxemia comes as a result of ventilation perfusion mismatch as a result of three possible mechanisms occurring again at the vascular level as opposed to the alveolar level. One, there's a failure of a hypoxemic pulmonary vasoconstriction. Two, there's macro or microthromboses at the pulmonary vasculature. And three, possibly endotheliitis or endothelial inflammation. So again, at the level of the vasculature and not the alveoli. So just to review the normal mechanism of hypoxemic vasoconstriction, if you have decreased alveolar oxygenation in the lung region, the normal vascular response is to vasoconstrict of the pulmonary artery branches in that region, thereby redistributing blood away from the poorly ventilated alveoli. And failure to do so results in VQ mismatch. There is some evidence that this exists. This is a dual energy CT showing increased amount of blood volume proximal to regions of consolidation in a patient with COVID-19. So you can see the small arrows over here on the left, indicating dilated pulmonary blood vessels, and the large green arrows over here on the right, indicating increased blood volume in areas of areas of consolidation. So this represents really a failure of that normal hemostatic mechanism. What about microthrombi? This is one of the first autopsy series that came out of New Orleans. And the authors here demonstrated that the dominant pathologic process was, number one, diffuse alveolar damage, but two, a lot of thrombosed small vessels. And the authors stated that the burden of small vessel pulmonary thrombi and platelet aggregation is novel and an important finding specific to SARS-CoV-2 and extends beyond what is typical seen in diffuse alveolar damage. This is the growth pathology, again demonstrating the microthrombi. This is another autopsy series demonstrating not only thrombosis, but this vascular endotheliitis. So they compared 7 patients who died from SARS-CoV-2 to 7 patients who had died from H1N1. I guess they took the lungs out of the freezer. And then also compared them to 10 control subjects that were matched. And what they found was the COVID long did look different than the typical H1N1 ARDS model. They were much lighter in weight, and H1N1 looked much more like typical ARDS with floor diffuse alveolar damage, massive interstitial edema, extensive fibrin deposition, and the COVID long looked a little different. They also demonstrated that a lot of microthrombi, in fact, the alveolar capillary microthrombi were 9 times as prevalent in the COVID patients. And again, on micro CT, you can see the total occlusion of the precapillary and postcapillary vessels. They further demonstrated severe endothelial injury in these patients in COVID-19 compared to controls. And lastly, they pulmonary vasoconstriction or thrombosis or endotheliolitis as the underlying pathophysiology, and perhaps we should be managing these patients sort of differently than conventional ARDS management. There are naysayers, however. Many challenge the notion of this CARDS concept, stating that ARDS is just ARDS and we should really not change our management on just bedside intuition and one small study. So, and actually, if you look at most of the studies that recorded compliance, particularly the studies in the US, they actually do match the compliance levels of previous well-known ARDS studies. So again, this disease process is probably along a spectrum, and I would argue that the best management strategy is probably to adapt to the individual needs and not one ventilation protocol. So given the evidence of microthrombi within the pulmonary vasculature, as well as many, many case series that's demonstrated macrothrombi, there is some evidence as well that anticoagulation is particularly beneficial in the critically ill patient. For example, the study up here demonstrating the higher D dimer and your higher sepsis-induced coagulopathy score, those patients did benefit from anticoagulation. We decided at GW that all of our patients in the ICU would get full dose anticoagulation. But this was not just to serve as an anticoagulant. We also have known for a long time that heparin and Lovenox have anti-inflammatory properties as well as possibly endothelial protection. So I think this is a good segue into that cytokine storm. We've known a long time that there's tremendous crosstalk between coagulopathy and inflammation, and the activation of one system amplifies the other, and if unopposed, may result in tissue damage or multi-organ system failure. What is cytokine storm? Cytokine storm is basically an uncontrolled immune activation secondary to a trigger, such as a medication, a malignancy, or a virus. And as a result of this uncontrolled immune activation, there's a release of various different cytokines and chemokines, including IL-1, IL-2, IL-6, TNF-alpha, for example, leading to a whole host of clinical scenarios, such as fever, cytopenia, and acute phase reactions, as well as organ dysfunction, including vascular destruction, tissue necrosis, and ARDS. There are multiple studies that have demonstrated evidence of this cytokine storm, elevated D dimers, elevated LDH, elevated IL-6, elevated serum ferritin seem to be higher in non-survivors. Well, what about the timing of this inflammatory process in the cytokine storm? It seems to occur about 1 to 2 weeks into the clinical course, basically when the viremia is settling. So these outcomes, it's sort of question, are these patients dying from the virus or are they dying from the inflammation itself? If you compare the clinical scenario of survivors to non-survivors, you can see they actually match quite well. However, the difference, the non-survivors, it's really about day 10 and day 12 where they start developing the sepsis and ARDS. And it's about into your second week where the patients start developing that's the clinical syndrome of cytokine storm, including acute kidney injury, acute cardiac injury, and then eventually secondary infection and death. So how does one suppress the storm? So we use some of our SARS-1 and MERS experience to look at this, and there is evidence that both reducing the viral load as well as controlling the inflammatory response does impact outcomes. So what about steroids? Steroids being sort of the gorilla or guru of all immunosuppressants. There's great rationale for the use of steroids. It's cheap, it's readily available around the world, and nothing else seemed to be working for our severely ill patients. As many as you know, remdesivir does speed the recovery, but that's really in the less sick population. By the time they come to us in the ICU, it really doesn't impact them much. There is a history of steroid use in similar viral infections. On MERS, for example, in SARS-CoV-1 and influenza, all of these studies actually used high-dose steroids and not small-dose, low-dose steroids. But nevertheless, all of these scenarios did not demonstrate benefit with the use of steroids. In fact, some of them actually demonstrated increased complications, such as persistent viremia and increased mortality. So at least initially, the WHO did not support the use of glucocorticosteroids in our COVID-19 patients. There is some evidence, at least on some of the early Chinese studies, that steroids may provide some benefit. This is a retrospective study in 201 patients in Wuhan, China. 84 patients had developed ARDS. 50 of those patients were treated with methylprednisolone. We don't know what the timing of the dosing or the dosing. It was not stated in the paper. Nevertheless, they did demonstrate that there was some mortality benefit with the use of methylprednisolone. The recovery trial is a very large trial conducting over 11,000 patients in the UK. Patients are randomized to either Kaletra, low-dose Decadron, azithromycin, hydroxychloroquine, or standard of care. They subsequently can get either no additional treatment or convalescent plasma, and then if they have further evidence of cytokine storm, they could receive, again, either no treatment or tocilizumab. The patients who are in the dexamethasone arm receive 6 milligrams daily for 10 days if approved by the attending. And what they found was in this recovery trial, the 28-day mortality by respiratory support, those patients who were receiving mechanical ventilation, so the really sick patients, were the patients that benefited most from the use of low-dose Decadron. They also found that you were likely to benefit from Decadron if you were less than 70 years old, if you were a man, although women still did benefit, and if your days since the onset of symptoms were greater than 7 days. So again, speaking to the timing of this inflammatory cascade. What about tocilizumab? Tocilizumab is a recombinant humanized anti-IL-6 receptor monoclonal antibody. It's probably received the most attention given its effectiveness in cytokine storm related to CAR T therapy, which is a syndrome that notably resembles COVID-19 given its ARDS pattern. There are multiple studies on tocilizumab. Most of them are single studies, single center trials, very small. The majority of them really demonstrate that toci does what it's supposed to do. It reduces your fever and brings down your inflammatory markers. But the mortality data is really quite limited. This is one study in CID that demonstrated in mechanically ventilated patients with COVID-19. It demonstrated a 45% reduction in hazard ratio of death. There were more superinfections in the toci group. However, the mortality was not higher in that co-infected group. So this is what tocilizumab looks like at GW. This is a 64-year-old man on high-flow nasal cannula with fevers, increasing inflammatory markers. He receives tocilizumab twice. You can see his ferritin had come down, his CRP had come down, but unfortunately the patient himself did not survive in the end. And this is a recent announcement from Roche looking at this phase 3 randomized double-blind placebo-controlled trial of toci versus placebo. And unfortunately, no clinical improvements at 4 weeks, no difference in mortality, no difference in event-free days. There was, however, no difference in infection, superimposed infection seen. There are several other immune modulating therapies, IL-6, IL-1, IMAB, which we're currently studying at GW, anti-complement, JAK inhibitors, IVIG, all under investigation. So I just want to take a minute to talk about extracorporeal blood purification treatment. This is the process by which inflammatory markers factors are removed via plasma exchange or absorption or filtration. And blood is basically flows through a filter, such as a PMX cartridge, which fibers that are laced with either polymyxin B or heparin and sulfate, for example. And the endotoxin is removed or purified, and blood is then returned to the body, just similar to dialysis. And we were participating in 2 studies looking at this blood purification concept, 2 sepsis studies. One we had done before called Euphrates and one called Tigris. And the studies in sepsis require that we obtain an endotoxin activity assay or an EAA level. An endotoxin activity assay is an FDA-approved device. And basically what it does is it measures the oxidative burst produced by neutrophils in the presence of endotoxin or LPS on the wall of a gram-negative organism. It is predictive of mortality in gram-negative sepsis. And while COVID-19 is a virus, there are some reports of bacterial translocation from the gut or the lungs as a possible mechanism for the multi-organ system failure that we see in COVID-19. So because of this theory, we decided that we would measure EAA levels in our COVID-19 patients in the unit. So we drew EAA levels on 78 GW ICU COVID patients. 8 of the 70 patients did have positive blood cultures, and to no surprise, they had either intermediate, high, or severely high EAA levels. Surprisingly, though, however, the patients with COVID but did not have bacteremia, so this was 2 negative blood cultures, 81.4% of patients had intermediate or high levels of EAA. So this is just really hypothesis generating. Perhaps the gut translocation is contributing to the pathology here. So when we had a 24-year-old woman with COVID-19 pneumonia with profound ARDS, 3 pressors, febrile, state of cytokine storm, this was the note that was written by the attending. We have been at the patient's bedside most of the day. Yesterday, she started becoming more unstable and inflammatory markers were increasing. Despite constant bedside attention, including vent manipulation, proning, and neuromuscular blockade, her SATs dropped into the 30s and persisted while pressures escalated. Given her futile situation, she is now DNR and family hasn't been informed of her imminent demise. She did survive the night and her EAA level was 0.8. Because of her elevated EAA level and because she was only 24 years old, we decided we would throw the kitchen sink at her. And we approached the spectral company that was doing this blood perfusion study and were granted compassionate use to use this hemoperfusion system on this patient. And you can see after use, her D-dimer came down, her ferritin came down, her CRP, LDH, and troponin all came down after the hemoperfusion was started, and we did it for 3 days in a row. Her clinical status did improve, and she survived another 3 weeks. Unfortunately, she eventually died of her lung disease. And now this trial is now being converted into has been converted to an IRB trial, and we are actively enrolling patients with COVID-19 and perfusion, for hemoperfusion. So I just want to take a few minutes to just review our ICU COVID data that we collected. This is from a database that we had between March 17th and June 7th. We took care of 162 COVID-19 patients during that time that were admitted to the ICU. The majority of patients were admitted. April and May were definitely our busiest months. A quarter of the patients were transferred from outside hospitals. I will say those were our particularly sick patients. If patients were admitted to GW, 70% of the patients were transferred from the floor to the ICU. So very few, or less than a third of patients were actually immediately came from the emergency department. Most patients did come to the ICU within their first couple of days of admission. Our demographics, we only had 8% of our patients identified as white, 65% of our patients were Black, and 15% of our patients were Hispanic. If you look at the age distribution, this is really not necessarily a disease of the elderly. We really had a span of age, and we did take care of more men than women during this time period. If you look at our BMI, this is really fascinating to me. 47% of our COVID-19 ICU patients were obese. If you include patients that were overweight, 77% of our patients were either overweight and obese. And this is in contrast to the obesity rates in Washington, D.C., which are only at 24.7%. What about mechanical ventilation? So 63% of our ICU patients required mechanical ventilation, and 69% of the patients who required mechanical ventilation died within our patients. The overall average ventilator days was 11.1 days. Our average hospital length of stay for COVID-19 was 14.4 days. And you can see sort of a dramatic cutoff after about 2 weeks when the majority of a lot of our patients had died. And what about ECMO? We have taken care of 11 total ECMO patients. Unfortunately, we have had 6 mortalities. We have had 3 survivors, all of which have left the hospital. One of those patients was a patient with myocarditis and didn't have lung injury, and she was a young woman who survived, I really feel like, as a result of the collaboration and with ECMO. And we have 2 patients currently on ICU 5 on ECMO. The ELSO registry data now states around the world that the survivability of ECMO is now at 55%. But again, we don't know what the trigger is to put patients on ECMO at different institutions. The majority of those patients are on VV and not VA ECMO. So lastly, I just want to sort of a summary slide here. This is me on the left with a little bit of, I guess, self-care, trying to get some exercise on the bike while being here for my 100th day. That's Dr. Honig over there on the right with always a positive attitude and a thumbs up when she's about to go intubate a patient. And that's the middle note is a stick-em note that my 9-year-old son wrote to me and is on my bedside table. that reminds me of two important things. Number one, I have to work on his spelling. And number two, that I really appreciate the tremendous collaboration. The reason why I'm here and have been here forever at GW is the collaboration with all the departments here that enabled us to stay afloat. And let's hope that we do not get another surge. And with that, I thank you so much, and I am open and available to any questions.
Danielle, thanks. Take a deep breath now.
I told you I'd get through those slides.
Yeah, I thought Judy Shaw talked fast, but I must say I think you might have overcome that for those that
I apologize for that.
remember Judy. But no, I think it was very clear, and it was exactly what I think we needed to hear, because we knew what we did in the hospital, what we did in the clinics, but to hear what other people were doing also at GW is really, really enlightening. Now, anybody that has any questions can put in the chat or to Tiger text me, and I'll be glad to answer. But let me ask you, could you give us some data about how safe things were working in the ICU? How many of your colleagues turned positive, or your staff, or any data on that? Because I think people are really interested in that.
Yeah, absolutely. I would almost argue that after doing this for several months, that working in the ICU is safer than going to the supermarket, I think, because of our PPE. We had one intensivist who got COVID from working here. We did have another intensivist, but had gotten that from the community. So only one doctor that I know of, and he absolutely recovered. We did do GW did an antibody study and tested the antibodies throughout many healthcare workers in the ICU, and there was only a 4% positivity rate. So that's really quite low, and none of our healthcare workers in the ICU got sick.
Danielle, the 4% rate is correct, although a number of those people did report having a febrile illness prior to it. So maybe a few more people got sick with mild illness. And a few of those in the 4% group actually had COVID, and they just wanted to see if they had antibody.
Correct.
But, I want to ask you something about the endotoxin story.
Yes.
It's sort of well known that for example, gram-positive bacteremia is associated with endotoxemia because of gut translocation. And so I'm not surprised that this happens. But what I would expect is you gave something to stabilize the membrane, i.e. steroids, early, that you should prevent some of that. I mean, septic shock, steroids have failed septic shock over and over again, unless in an animal model, at least if you give it very early. If you give it 20 minutes before you give the bacteria, they all survive. So is it possible you're not seeing I couldn't follow the data well enough, that you're not seeing benefit with early steroids because most of those patients survive anyhow? I'm trying to sort this out because I keep thinking we got to treat this earlier and earlier rather than late when they're pretty far gone. But I couldn't follow the data on that point.
No, absolutely. I mean, I think the theory is that if you can get the virus early, when the viremia in the first week, that is absolutely necessary. And the trigger as to when you stop this cytokine storm is really unknown. If you wait too late, it doesn't matter, and you give an immune modulator, they're just going to get a superimposed infection. So the timing as to when to do this is really, we just don't know. And we just don't know that we have one study that demonstrates that steroids work, but as you know, steroids in other inflammatory settings such as ARDS, traditional ARDS, does not necessarily work. So we just don't know the answer.
Danielle, did those patients that we delayed intubating and tried other measures, once we intubated them, did they have a lower mortality on intubation? Was there any evidence that we did any good just by delaying their ventilation?
No, there's just no, once they were intubated, their mortality is very high, but there's no evidence to suggest that the delay caused harm, at least that we can tell. And there's no evidence out there, no randomized control trials certainly to test this. But there's no data out there that we don't know, but delay. Correct.
Yeah, okay. So one of the things that's coming up now with a lot of the athletes is their concern about having cardiac involvement. Do we see any acute cardiac involvement in the ICU?
Yes, a great case actually of a patient, a young woman in her early 20s. She came in to an outside hospital with altered mental status, hemodynamically unstable. Echo and Swan showed an EF of less than 10%. She was brought over here, put on VA ECMO and an Impella. Her lungs were clear. She really did not have the typical lung findings. This was really much more of a classic myocarditis picture. She received 3 days of steroids. Within 10 days, her ECMO was decannulated, her Impella was removed, and she was discharged from the hospital out. A lot of right heart failure, obviously. We think there were a lot of pulmonary embolisms that were occurring. We couldn't really record or get many ultrasounds, but a lot of right heart failure, obviously. But we did see a few cases of myocardial injury.
Do you have any idea of how many of these patients, when they left the hospital, were leaving on oxygen still and still have significant impairment and might continue to have impairment?
Yeah, so I find that actually the neurologic outcome of patients fascinating. There is something called post-ICU syndrome. And what this condition basically is as a result of having multi-organ failure, being on a ventilator for a long time, being sedated for a long time, there are various different complications that happen, either from a mental health standpoint, for sort of like a PTSD standpoint, cognitive delays and physical delays, particularly with respect to energy level and lungs. And I think we're starting to see a lot more of this as we're seeing more and more survivors. How many patients actually require oxygen long-term? That I don't think we know that data yet because we haven't had that many survivors for a long period of time. So I don't know the outcome, but I think that is more to come.
I thought the ICU syndrome was the exposure to Mike Seneff, but
yeah, no, there's that too.
Yeah. That would take a while to get over, I would imagine. So.
We are also looking at our sedation. The sedation requirements for patients with COVID-19 are phenomenal, astronomical amounts, and we don't know why. We're looking into our data right now as to why that is.
Gary, recognizing that we don't have any before data, but is there anybody looking at, for example, PFTs 3 months after recovery or cardiac echoes 3 months after recovery? To see it with age-matched controls. Is there anybody looked at that?
I'm sorry, you broke up a little bit there. Age-matched.
That's what I was asking is, I know we don't have any before data, but if you look at PFTs with age-matched controls 3 months later, 3 months after recovery, has anybody looked at that? Or has anybody looked at cardiac echoes 3 months after recovery?
So I do know of a study actually that was presented last week, but I've looked at an MRI study. These were of patients. 2/3 of the patients actually were not sick patients. They were patients who were COVID patients from the outpatient world. A third were in the hospital. All of them had recovered, and they did MRIs actually of those patients at 70 days, or average of 70 days. And a large majority of those patients demonstrated a lot of inflammation on those MRIs, those cardiac MRIs.
I enjoy it when it's colder. I'm sorry. It is colder than it usually is.
I do not know
their computers and their phones. Yeah, Danielle.
Oh, sorry. So there is some data, the long-term data with respect to cardiac MRIs, and I'm sure there's more for cardiac echo. I'm not familiar with PFT data.
Do we have much experience with antibody-rich plasma?
So we did use it. We used it a lot more sort of earlier on, and I think most of the data was demonstrating that if it was going to be effective, it was going to be effective in the patients that were less sick earlier on. So you have to sort of neutralize the process much earlier on. So we committed to using plasma for patients.
Okay, once again, here.
For the skip breakfast.
Oh no. Okay.
So by noon, I'll be like, I'm done.
Everybody, please mute their computers. We don't need to hear your breakfast conversation. What about remdesivir?
Oh, thank you. Yeah, that would be good.
So remdesivir, the latest studies demonstrated basically patients will improve or have symptom resolution or improvement in symptoms by 4 days. But those are really for patients who are less sick. So these are patients for the floor and really not meant for the ICU. For those patients who are critically ill, it really showed no benefit. 5 days of remdesivir, you can use it for 10 days. But once that data came out, we stopped using our limited amount of remdesivir and really started using it on the floor.
So overall, the data seems to imply that over the last few months, the mortality rate has decreased somewhat because of experience in treating these patients. Do you think we saw that also as time went by?
I think the virus is changing a little bit. I do think that we got better. I think we got more patient. We have to recognize that these patients, some of the lung disease takes a long time to get better. We've had some patients that required, 4 or 5 weeks on the ventilator and did eventually get better. I think we got better with our selection process with ECMO and continue to do so. So I think people are getting better at it. I think it does make a difference what hospital you're in. It does require a lot of sophisticated care with the ventilator and with nursing. So I think people are getting a little bit smarter, but there is no magic bullet out there. Decadron did show one positive study, but it is not by all means a magic bullet.
And the lung compliance, how does that compare with SARS or MERS? I don't know if you mentioned it or not, but I missed it.
There are really not that many reports demonstrating that in SARS and MERS that the compliance is like this particular virus. They're more typical and classic of ARDS, looking more similar, like, for example, in influenza, where you have a stiffer lung.
And the last question that I have is someone asked about, I don't think we had any experience with using one ventilator on 2 patients, but there was some experience, I think, in New York on that.
Yeah, most of the recommendations actually from respiratory societies are recommending that we not do that. We were able to get enough ventilators. We had 150 ventilators and 150 beds. So we actually had the capability of putting every patient on an individual ventilator. So we did not need to do that, and we did not plan on doing that.
And where do we stand now with numbers? How many patients are in the ICU at this point?
8. So we ranged in the last several weeks, we've ranged between 6 and 8. We are seeing an increased number of patients that are coming in with COVID, but just happen to have COVID. So for example, a subarachnoid patient or a trip and fall or appendicitis or something like that, and just happen to have COVID. So I think that's more of a public health scare, that there are a lot of patients that are asymptomatic out there and they're coming in for different reasons.
And one question was just wondering, what was our longest, our longest surviving patient who was on either ventilator or ECMO that survived?
Yes, we had in the 50s or 60s, I forget how many days, I think it was probably I think it was 50 something days, we had a patient on ECMO who walked out of the hospital.
Wow. So, I mean, it is amazing when you tell the story of how quickly the group in the ICU and the group in the hospital and just about everybody, mobilized the care of these patients and the safety. And the safety speaks for itself, but it just was an amazing, and let's hope we don't have to go through it again. But thanks for coming. Thank everybody in the ICU for everything they did. And next week we'll hear about the tales from the emergency department. Danielle, thanks again.
Excellent. Thanks. Bye.